The endocrine disorder syndrome of inappropriate antidiuretic hormone secretion, often referred to as SIADH, is a common condition in which abnormally elevated levels of antidiuretic hormone, or ADH, are secreted, resulting in the body retaining excess water. Trauma to the brain are often factors predisposing of the syndrome of inappropriate antidiuretic hormone secretion, with acute brain injuries accounting for the majority of cases. SIADH can be triggered by other factors as well. They can include central nervous system disorders such as brain tumors or cerebrovascular accidents such as stroke. Cancers, especially of the lungs, lymphatic system, or gastrointestinal tract, can be causes of SIADH, as can chronic pulmonary disorders, such as COPD. HIV, and even certain medications can trigger the syndrome of inappropriate antidiuretic hormone secretion. Diuretic hormone, ADH, is produced by the hypothalamus, then transferred to the posterior pituitary gland, where it is stored and secreted. ADH is crucial to maintaining the body's fluid balance. SIADH disrupts the control of ADH secretion, causing the body to retain excess water. This abnormal retention of water by the body has disruptive effects upon the body's fluid and electrolyte balance, which manifests in a number of ways, especially upon the body's sodium. Clinically, this presents as hypoosmolar hyponatremia, hypernatremia, which is associated with a low plasma osmolarity. Classic symptoms of the syndrome of inappropriate antidiuretic hormone secretion are often in relation to the body's fluid excess and hyponatremic state. Weakness, fatigue, muscle cramping, and confusion are all common symptoms. Individuals presenting with SIADH symptoms may report nausea or vomiting. As the body is retaining excess fluid, individuals presenting with symptoms of SIADH will have an overall decrease in urine output and experience increased weight gain. As the hyponatremia becomes more severe, so too will the symptoms experienced. If the sodium levels decrease severe enough, the individual may experience extreme lethargy, cerebral edema, and be at risk for seizure. The clinical diagnosis for the syndrome of inappropriate antidiuretic hormone secretion necessitates the measuring of the body's sodium, electrolyte, and water levels in blood and urine. Hematocrit, plasma osmolality, urine-specific gravity, and urine osmolality are common diagnostic tests ordered to measure these levels. A confirmed diagnosis will see hypoosmolar hyponatremia, which presents with a serum sodium level below 135 milliequivalents per liter, a urine sodium excretion level above 20 millimoles per liter, and a serum osmolality below 280 milliosmoles per kilogram. SIADH presents with a urine-specific gravity above that of 1.030. These hypoosmolar hyponatremic levels, urine sodium and osmolality levels, when in the presence of otherwise normally functioning renal and hepatic system, ensure the confirmation of the syndrome of inappropriate antidiuretic hormone secretion. Because SIADH can be caused by various factors, such as cancer, central nervous system disorders, certain drug therapies, or other factors, a crucial step in the treatment of diagnosed SIADH is to directly treat its underlying cause. Once the underlying cause has been addressed, the next step in the treatment process of the syndrome of inappropriate antidiuretic hormone secretion is to stop or avoid any medications or treatments that would stimulate or exacerbate the secretion of antidiuretic hormone. In severe cases of SIADH, as when related to small cell lung cancer and extreme hyponatremia, a recommended course of treatment can include administering 150 milliliters of 3% hypertonic saline over a period of 20 minutes. This process is repeated until the body's serum sodium levels increase by at least 5 millimoles per liter. This increase is kept to 10 millimoles per liter for the first 24 hours of treatment, and then allowing for an 8 millimoles per liter increase each additional 24-hour period, with a serum sodium level goal of 130 millimoles per liter total. It should be noted that causal treatment be started only after an initial increase of 5 millimoles per liter. If the SIADH symptoms are mild, and serum sodium is greater than 125 millimoles per liter, then the only necessary treatment may be fluid restriction of 800 to 1000 milliliters per day. The purpose of the restriction is to attain weight reduction, and facilitate a gradual rise in serum sodium concentration and osmolality. Improvement in symptoms should evident with normalized level of serum sodium and osmolality. Patient may experience discomfort due to thirst from the fluid restriction. A loop diuretic, such as furosemide, may be recommended to promote diuresis. This treatment is only recommended to patients with serum sodium levels of at least 125 millimoles per liter, as diuretics can promote further sodium loss. Additionally, loop diuretics may also increase the loss of potassium, calcium, and magnesium, thus supplemental electrolytes may be needed. Dimeclocycline also may be given to block the effects of antidiuretic hormones on the renal tubules, resulting in more dilute urine. Vasopressor receptor antagonists, which block the activity of antidiuretic hormones, are used to treat euvolemic hyponatremia in hospitalized patients. Conivaptan is a common antagonist of vasopressin given intravenously. Tolvaptan is a common oral antagonist. Neither should be given to patients with liver disease, as each can be hepatotoxic, and thus worsen liver function. Nursing interventions can include observing for symptoms of SIADH such as low urine output with a high specific gravity, a sudden weight gain without edema, or a decreased serum sodium level. In patients that have diagnosed SIADH, the nurse should monitor the patient's intake and output, vital signs, and heart and lung sounds. The nurse should also obtain daily weights, reporting weights above 1 kilogram per day, and observe for signs of hyponatremia, such as seizures, headache, vomiting, and decreased neurologic function. When treating patients with chronic SIADH, implementing a fluid restriction of 800 to 1000 milliliters per day is recommended. The use of ice chips or sugarless chewing gum, if approved by the healthcare provider, can help decrease thirst. The nurse should use 0.09% sodium chloride, instead of water, to flush patient tubes, mix medications, or dilute feedings given enterally. Additionally, the nurse should monitor for fluid overload, heart failure, and water intoxication by observing for distended neck veins, such as jugular vein distension, and auscultating for crackles in lungs. Other patient signs to observe for include confusion, headache, edema, or disorientation. It is important to correct hyponatremia slowly. Serum sodium levels should not increase by more than 8 to 12 millimoles per liter within the first 24-hour period of initial treatment. Increasing serum sodium levels too quickly, or by too much, can increase the risk for osmotic demyelination syndrome, which can cause permanent damage to nerve cells in the brain. A fluid restriction of 500 milliliters per day may be needed for those with severe hyponatremia. With severe cases of SIADH, the nurse should implement seizure and fall precautions, especially if the patient has an altered level of consciousness or mentation. Additionally, positioning the patient's head of the bed flat or elevated no more than 10 degrees enhances venous return to the heart, and increases left atrial filling pressure, which helps reduce the secretion levels of antidiuretic hormones from the pituitary gland. Keep in mind, while the patient is in bed, frequent turning, positioning, and range of motion exercises are important to maintain skin integrity and joint mobility. Patient education is crucial. If the patient is taking a diuretic, instruct them to monitor for changes in fluid balance by weighing themselves daily. If the diuretic prescribed has the potential to waste certain electrolytes, such as potassium, educate the patient on the importance of daily supplements as replacement therapy. Sodium replacement may be necessary as well. Educate the patient that these can be found in food sources. The patient should be educated to notice the signs and symptoms of fluid and electrolyte imbalances, particularly those involving sodium and potassium. If the patient is prescribed certain antibiotics, such as dimeclocycline, instruct the patient that it may be contraindicated to take with certain supplements, antacids, or milk. Consulting with the patient's healthcare provider can ensure there are not inappropriate interactions. Additionally, while taking certain antibiotics, such as dimethylcycline. The patient should be educated to monitor for yeast infection, avoid prolonged exposure to sunlight, and to contact their healthcare provider if they experience diarrhea. If the patient is being treated with hypertonic sodium chloride IV fluids, educate them to report any difficulty breathing, to obtain weights daily, to wear a medical bracelet, and to restrict fluid intake. Additionally, educate the patient that experiencing tremors or disorientation could be a sign of hypervolemia, and it can increase risk for seizures. It is important the client understand they cannot drink alcoholic beverages during this treatment. Thank you for taking this time to explore the syndrome of inappropriate antidiuretic secretion with us. We have covered the epidemiology, etiology, and pathophysiology of this common condition. We have learned about its common signs and symptoms, and the clinical criteria to diagnose it. We have viewed the treatment options, and how the role of the nurse plays into those various treatments. And, importantly, we have covered the crucial education the nurse should deliver to patients at risk for or recovering from the syndrome of inappropriate antidiuretic hormone secretion. Go forth with this knowledge, and be the best nurse you can be.